Hi, my name is Dr. Al-Sohaily. I'm a gastroenterologist at Campbelltown Hospital and a PhD student at the Garvan Institute of Medical Research in Sydney, Australia. In this video, I'll discuss the prognostic role of MCC methylation in colorectal cancer. Colorectal cancer is a major health problem. In the United States, close to 150,000 new cases and close to 50,000 deaths are reported from the disease each year. Over the past 2 decades, major advances have been achieved in the field of molecular genetics in colorectal cancer. The most important are understanding the role of microsatellite instability in hereditary and sporadic cancers, and secondly, the finding of epigenetic alteration as an alternative pathway to colorectal carcinogenesis. This led to identification of a subgroup of colorectal cancers called the CpG island methylator phenotype, or CIMP high tumors. One of the genes involved in colorectal carcinogenesis is mutated in colorectal cancer gene, or MCC gene. This is a gene which was first discovered in 1991, and it's located on chromosome 5 in close proximity to the APC gene. It's found to be mutated in small percentage of cancers, but to be methylated in about a third of cancers. So the aim of my study was to assess the frequency in a larger cohort and to assess the prognostic role of MCC methylation in a colorectal cancer, in a large cohort of colorectal cancer. To do this, I collected about 400 archived specimens, colorectal specimens with matching normal tissues. Then DNA was extracted and bisulfite converted to enable methylation analysis using methylation-specific PCR. To detect CIMP high tumors and MSI high tumors, 5 CIMP markers were detected by methylation-specific PCRs, and 4 mismatch repair proteins were detected by immunohistochemistry. Clinical and survival data were pre-recorded in a prospectively collected and well-maintained database. Now to the findings. Colorectal MCC methylation was found in about 36% of colorectal cancer specimens. It was found to be more common in women, patients who are older at age of diagnosis, and more commonly in the right colon comparing to the left colon. Histologically, they found to have more aggressive phenotype, being poorly differentiated, larger tumor size, locally advanced tumors, circumferential, and they have more mucinous and signet ring histology. When we looked at survival, the patients with MCC methylation have worse short-term survival at 1 and 2 years comparing to patients with no MCC methylation, and this was independent of age and stage of the disease. A sub-analysis to look at the survival after adjuvant chemotherapy found that patients with MCC methylation have no survival advantage after receiving adjuvant chemotherapy comparing to patients with no MCC methylation. So in summary, MCC methylation was seen in about a third of colorectal cancer, was seen in a more aggressive phenotype, and although long-term survival is indifferent, short-term survival seemed to be worse in patients with MCC methylation, and they seem to respond less favorably to postoperative chemotherapy. This has a major clinical implication, as the current treatment guidelines recommend the use of chemotherapy for patients with node-positive disease and node-negative but with high-risk features. Using these guidelines, a significant proportion of patients receiving chemotherapy would have little benefit or no benefit from chemotherapy. So identifying molecular markers that could predict response to chemotherapy would help to better stratify therapy and better patient selection. So I believe that the role of MCC methylation as a predictive marker to chemotherapy responsiveness in patients with colorectal cancer deserve further evaluation. Thank you.